Let's talk about accelerated automaticity rhythms. There's premature contractions. Premature contractions can be atrial, junctional, or ventricular in origin. Premature atrial contractions. To diagnose premature atrial contractions, we need to consider normal sinus rhythm. The consistency of the R2R interval allows the prediction of the timing of the very next QRS complex. However, if a beat of atrial origin occurs early, it is termed a premature atrial contraction, or PAC. Now, these are often followed by a compensatory pause. Therefore, what you should see is the first R to R interval is short and the next R to R interval is longer. In the otherwise healthy patient, premature atrial contractions, PACs, are usually a normal finding. However, the clinical context is terribly important. Exactly the same arrhythmia with a new onset immediately after cardiac surgery may have more sinister significance. In the operating room or the ICU, the development of an increasing frequency of premature beats, especially if they are multifocal from different regions of the atrium, or their junctional or even ventricular premature beats, this is an ominous occurrence, and an arrhythmogenic milieu must be excluded. That is, the milieu, the environment immediately around the atrial myocytes, may be one that predisposes to arrhythmias. In some patients, the PACs are related to anxiety, or excessive caffeine, or nicotine from cigarette smoking. They may be related to alcohol, and sometimes to recreational drug abuse, such as cocaine and amphetamines. The impact of vaping on PACs and PVCs is yet unknown. In a minority of cases, the PACs are a manifestation of serious underlying disease, heart failure, myocardial damage, cardiomyopathy, or digoxin toxicity. Usually, no treatment is necessary other than abstinence from the provoking stimulus as listed above. If this does not work, then small doses of beta blockers or calcium channel blockers, such as verapamil, or a sedative such as diazepam, are occasionally indicated. Now, let's consider this condition, wandering atrial pacemaker. In this condition, the impulse can arise from the atria, the sinoatrial node, or the atrioventricular node. This arrhythmia is usually due to excessive parasympathetic activity. It is often asymptomatic and relatively benign. It rarely requires any treatment. A very small number of patients may have ischemic heart disease or digoxin toxicity, so work through the arrhythmia checklist to exclude serious causes. It may progress to other atrial arrhythmias. In the examples shown, note the very variable P wave size, shape, and even direction. Now, moving on, let's consider atrial flutter. It's a very common arrhythmia. This arrhythmia may be due to one or more ectopic foci, but often it is caused by a re-entry mechanism. The atrial ectopic foci generate impulses at 220 to 360 beats per minute, and each of these is usually associated with an atrial contraction. This rapid atrial rate is seen on the ECG as flutter waves or large F waves, and examples are shown. This arrhythmia has a baseline with a sawtooth appearance. The ventricles cannot keep pace with this fast rate, and commonly there is some associated degree of AV block, at least 2 to 1, but it may be 3 to 1 or even 4 to 1 block. The degree of block is usually consistent, although it may change abruptly from a manageable 3 to 1 to an alarming 2 to 1. It is essential to avoid any interventions which may reduce the degree of block, as an increase in rate, which we call rapid ventricular response, can seriously compromise ventricular filling time such that cardiovascular collapse may ensue. The symptoms of this arrhythmia depend on the degree of block. Both a very high and a very low degree of block may be associated with reduction of cardiac output and blood pressure. Atrial flutter may be caused by ischemic heart disease or heart failure. Any process that damages or distends the atria may cause atrial flutter, as may an increase in sympathetic tone. Other common causes are rheumatic heart disease and thyrotoxicosis. Because the atria contract normally, atrial flutter does not usually cause thromboembolic complications, such as the ones we see associated with atrial fibrillation. The treatment is that of the underlying condition. If this has been addressed and the patient remains in atrial flutter, then digoxin or electrical cardioversion are options. Atrial flutter usually cardioverts easily at low energies, and in the absence of mechanical distension of the atria, will usually cardiovert easily at low energies as long as we have the absence of damaging stress on the atrial myocytes. Atrial enlargement can make successful, long-lasting cardioversion to sinus rhythm difficult to achieve. Now, moving on again, a very important topic, atrial fibrillation. This arrhythmia has similarities to atrial flutter. It may also be due to ectopy, but it can be caused by a re-entry mechanism. The atrial ectopic foci generate impulses at greater than 360 beats per minute or more, which is way too fast to generate a coordinated atrial contraction. Atrial fibrillation may be associated with small waves, little F waves, the appearance of either coarse or fine undulations in the baseline. However, the baseline may be flat, and the only indications of atrial fibrillation may be the constantly varying R2R interval in the EKG. Once again, the ventricles cannot keep up with this fast rate, and there is an inconsistent degree of block. This manifests as what we call an irregular ventricular response, which may nevertheless be very rapid, and our old foe, the rapid ventricular response, may occur at any time. The difference between the ventricular rate and the radial artery rate is referred to as a pulse deficit. That is, in fibrillation, the heart rate can be so fast that some contractions occur with an empty ventricle, and so an electrical event may not be associated with a pulse at the radial artery. Some of the symptoms of this arrhythmia are related to the loss of atrial augmentation of ventricular preload, and this is referred to as loss of atrial transport or atrial kick, with a reduction in ventricular preload of 15 to 20%, and this may be associated with a similar reduction in stroke volume, cardiac output and blood pressure, especially in elderly patients or those with a very stiff left ventricle. I do, however, want to really emphasize, though, that most of the decrease in stroke volume which occurs in fast atrial fibrillation is due to a decreased duration of diastole, which decreases diastolic filling time for the ventricle, much more so than the loss of atrial transport. Atrial fibrillation may be caused by ischemic heart disease or heart failure. Any process that damages or distends the atria may cause atrial fibrillation. Other causes are rheumatic heart disease and thyrotoxicosis. Do not forget to use the arrhythmia checklist, especially for AFib of recent onset. Because the atria do not contract during atrial fibrillation, it is associated with the development of atrial thrombus in the left atrial appendage with consequent thromboembolic complications, and so this condition requires anticoagulant prophylaxis of thromboembolic complications requiring anticoagulation. The treatment is that of the underlying condition. If this has already been addressed, then synchronized cardioversion is an option. Atrial fibrillation does not cardiovert easily, particularly in the presence of mechanical distension of the atria. Digoxin is used to slow the ventricular response rather than being an intention to cardiovert. Atrial fibrillation is a massively important subject. Of note, never cardiovert atrial fibrillation until somebody excludes the presence of thrombus in the left atrial appendage prior to an attempted cardioversion. Thank you for listening to this presentation.